Welcome to this audiobook entitled BPS Exam Preparations for Pulmonary Disorders and Gout. We will begin with asthma. For its management you can follow the guidelines listed here: National Institutes of Health, NIH, National Heart, Lung and Blood Institute, NHLBI. National Asthma Education and Prevention Program Guidelines, NAEPP. NAEPP Expert Panel Report 3. NIH Publication 085846. July 2007. They're available at https://www.nih.gov/health-topics/guidelines-4-diagnosis-management of asthma. Accessed September 4, 2018. Global Initiative for Asthma, abbreviated as GINA, Global Strategy for Asthma Management and Prevention 2018. Available at www.ganasthma.org/. Accessed September 4, 2018. As a way of definition, asthma is a chronic inflammatory disorder of the airways causing recurrent episodes of wheezing, breathlessness, cough, and chest tightness, particularly at night or early in the morning. During episodes, there is variable airway obstruction, often reversible spontaneously or with treatment. There is also increased bronchial hyperresponsiveness to a variety of stimuli. Regarding the diagnosis of asthma: 1. Episodic symptoms of airflow obstruction are present. 2. Airway obstruction is reversible. FEV1 improves by 12% or more after SABAs. 3. Alternative diagnoses are excluded. Let's look at asthma versus COPD. The cough is usually non-productive with asthma and productive with COPD. FEV1 is reversible with asthma but irreversible with COPD. Cough is worse at night and early in the morning with asthma. It occurs throughout the day with COPD. Asthma is often related to allergies and environmental triggers. Patients with COPD have a common history of smoking or exposure to other irritants. Asthma can be reversible. Lung damage from COPD is irreversible. 4. Regarding asthma-COPD overlap, abbreviated as ACOA. No single definition of ACO is well defined or commonly accepted. It is characterized by persistent airflow limitation and features usually associated with both asthma and COPD. Identified by the clinical features it shares with both asthma and COPD. It is marked by persistent airflow limitation with features of both asthma and COPD. If 3 or more features favor asthma, use diagnosis and treatment for asthma. If 3 or more features favor COPD, use diagnosis and treatment for COPD. If a similar number of features exist for both asthma and COPD, consider a diagnosis of ACO. See Table 1. 5. We will briefly look at exercise-induced bronchospasm. It presents with cough, shortness of breath, chest pain or tightness, wheezing, or endurance problems during or after exercise. Diagnosis is made with an exercise challenge in which a 15% decrease in FEV1 or peak expiratory flow occurs before and after exercise, measured at 5-minute intervals for 20 to 30 minutes. Pause the video and carefully scrutinize Table 1 summarizing diagnosis in adults: asthma versus COPD. Pause the video and carefully scrutinize Table 2 summarizing interpreting spirometry. Pause the video and carefully scrutinize Table 3 summarizing classification of asthma severity in adults and children. Pause the video and carefully scrutinize Table 4 summarizing assessing asthma control in adults and children. Regarding the treatment goals for asthma, they include: 1. Minimal or no chronic symptoms day or night. 2. Minimal or no exacerbations. 3. No limitations on activities, no school or work missed. 4. Maintenance of near normal pulmonary function. 5. Minimal use of SABAs. 6. Minimal or no adverse effects from medications. Pause the video and carefully scrutinize Table 5 summarizing the stepwise pharmacologic treatment of asthma. Pause the video and carefully scrutinize Table 6 summarizing the pharmacologic agents used for asthma and COPD. Pause the video and carefully scrutinize Table 6 summarizing the pharmacologic agents used for asthma and COPD. Pause the video and carefully scrutinize Table 6 summarizing the pharmacologic agents used for asthma and COPD. Pause the video and carefully scrutinize Table 6 summarizing the pharmacologic agents used for asthma and COPD. Pause the video and carefully scrutinize Table 6 summarizing the pharmacologic agents used for asthma and COPD. Pause the video and carefully scrutinize Table 6 summarizing the pharmacologic agents used for asthma and COPD. Pause the video and carefully scrutinize Table 7 summarizing inhaled corticosteroid daily dosing in children and adults. Pause the video and carefully scrutinize Table 8 summarizing different types of inhalation devices. Pause the video and carefully scrutinize Table 8 summarizing different types of inhalation devices. We will now briefly look at the use of long-acting antimuscarinic antagonists (LAMAs) for asthma. 1. Tiotropium respimat is the only LAMA indicated for long-term treatment of asthma. 2. 2017 GINA guidelines include tiotropium as add-on therapy in steps 4 and 5 for children 12 years and older and adults with severe asthma and a history of exacerbations. This can be accessed at www.ganasthma.org. 3. Evidence shows improved lung function and increased time to severe exacerbation. Let's move on to the pharmacologic treatment of asthma-COPD overlap, abbreviated as ACO. 1. If there are more features of asthma, use the treatment strategy for asthma. 2. If there are more features of COPD, use the treatment strategy for COPD. 3. If the clinical picture suggests ACO, start with a low or moderate dose ICS and usually add a LABA or LAMA. This can be accessed at www.ganasthma.org. Let's take a closer look at long-acting beta-2 agonists, LABAs. According to a U.S. Food and Drug Administration (FDA) safety announcement, issued because of safety concerns with LABAs, FDA Drug Safety Communication, www.fda.gov/drugs/drugsafety/postmarket drug safety information for patients and providers/UCM 213836.htm:1. The use of a LABA alone without a long-term asthma control drug such as an ICS is contraindicated because of an increased risk of severe worsening of asthma symptoms, leading to hospitalization and death in some children and adults. 2. LABAs should not be used in patients whose asthma is adequately controlled by low or medium-dose ICSs. 3. LABAs should be used only as additional therapy for patients who are currently taking, but whose asthma is not adequately controlled by, a long-term asthma control agent, e.g., an ICS. An FDA review found no significant increase in risk of serious asthma outcomes with LABA use in combination with ICS. FDA Drug Safety Communication, December 20, 17, 4. Once asthma control is achieved and maintained, patients should be assessed at regular intervals and stepped down, e.g., LABAs discontinued, if possible, and the patients should continue to be treated with a long-term asthma control agent, e.g., an ICS. 5. Pediatric and adolescent patients who need a LABA and an ICS should use a combination product to ensure adherence to both medications. Let's now discuss exercise-induced bronchospasm, diagnosis, prevention, and treatment of symptoms. 1. History of cough, shortness of breath, chest pain or tightness, wheezing, or endurance problems during exercise are suggestive of exercise-induced bronchospasm. 2. An exercise challenge can establish a diagnosis. 3. Long-term control therapy, if otherwise appropriate, initiate or step-up, should be used, particularly if exercise-induced bronchospasm is frequent or severe. 4. Pre-treatment with a SABA is appropriate before exercise. 5. Leukotriene modifiers, abbreviated as LTMs, can attenuate symptoms in 50% of patients, but onset is hours after administration. Regarding monitoring, we can use the following. 1. Peak flow monitoring. Symptom-based and peak flow-based monitoring have similar benefits, either is appropriate for most patients. Symptom-based monitoring is more convenient. Daily home peak flow monitoring may be considered for moderate to severe persistent asthma if the patient has a history of severe exacerbations or has poor perception of worsening of asthma symptoms. Personal best peak expiratory flow rate, abbreviated as PEFR, not predicted PEFR, should be determined if a peak flow-based asthma action plan is being used. 1. Personal best PEFR is the highest number attained after daily monitoring for 2 weeks twice daily when asthma is under good control. 2. Predicted PEFR is based on population norms for sex, height, and age. 2. Spirometry is only used in patients 5 years and older. At initial assessment. After treatment is started and symptoms are stabilized, that is 3 to 6 months. If there is prolonged or progressive loss of asthma control. At least every 2 years or more often, depending on response to therapy. And now we will briefly discuss the asthma action plan illustrated in Table 9. 1. It is usually symptom-based, equal benefits of symptom-based and peak flow-based monitoring. 2. It permits home treatment of an asthma exacerbation. 3. After initial treatment, immediate medical attention is needed if patient is at high risk of a fatal attack. Risk factors include asthma-related history of severe attack, previous intubation or intensive care unit admission for asthma equal to or more than 2 hospitalizations for asthma in the past year equal to or more than 3 ED visits for asthma in the past year, hospitalization or ED visit for asthma in the past month, using more than 2 canisters of SABA a month, difficulty perceiving asthma symptoms, social, low socioeconomic status or inner-city residence, illicit drug use, major psychosocial problems, and comorbidities, cardiovascular disease, other chronic lung disease, chronic psychiatric disease. Pause the video and carefully scrutinize Table 9 summarizing asthma action plan. Pause the video and carefully scrutinize Table 10 summarizing classifying severity of asthma exacerbations in the urgent or emergency care setting. 1. Regarding mild to moderate exacerbation, with an FEV1 of 40% or more. Administer oxygen to achieve oxygen saturation SaO2 of 90% or more, greater than 95% in pregnant women and those with concomitant heart disease. Use inhaled SABA as an MDI with valved holding chamber or nebulizer, up to 3 doses in the first hour. 1. The adult dose is albuterol MDI 4 to 8 puffs every 20 minutes for up to 4 hours, then every 1 to 4 hours as needed, or by nebulizer 2.5 to 5 mg every 20 minutes for 3 doses, then 2.5 to 10 mg every 1 to 4 hours as needed. 2. Pediatric dose, for those 12 years or younger, administer albuterol MDI 4 to 8 puffs every 20 minutes for 3 doses, then every 1 to 4 hours as needed. Use holding chamber, add mask if younger than 4 years, or by nebulizer 0.15 mg per kilogram, minimal dose 2.5 mg, every 20 minutes for 3 doses, then 0.15 to 0.3 mg per kilogram up to 10 mg every 1 to 4 hours as needed. C. OCS if no response immediately or if patient recently took an OCS. 2. In the case of severe exacerbation, with an FEV1 of 40% or less, A. Administer oxygen to achieve SaO2 of 90% or more than 95% in pregnant women and those with concomitant heart disease. B. Administer high-dose inhaled SABA plus ipratropium by MDI plus valved holding chamber or nebulizer every 20 minutes or continuously for 1 hour. C. Administer oral corticosteroids. 1. Adult dose is prednisone dosed at 40 to 80 mg per day in 1 or 2 divided doses until peak expiratory flow reaches 70% of predicted. 2. Pediatric dose, for those 12 years or younger, 1 to 2 mg per kilogram in 2 divided doses, to a maximum 60 mg per day, until peak expiratory flow reaches 70% of predicted. D. Consider adjunctive therapies, intravenous magnesium, intravenous ketamine, or Helix, if the patient is still unresponsive. 3. Let's discuss impending or actual respiratory arrest. A. We should do intubation and mechanical ventilation with oxygen 100%. B. Administer nebulized SABA plus ipratropium. C. Administer intravenous corticosteroids. D. Consider adjunctive therapies, i.e., intravenous magnesium or Helix, if the patient is still unresponsive to therapy. E. Consider admission to intensive care. O. Let's discuss managing exacerbations. ED or hospital after repeat assessment. 1. For moderate exacerbation, that is an FEV1 40% to 69%, A. Administer inhaled SABA every 60 minutes. B. Administer oral corticosteroid. C. Continue treatment for 1 to 3 hours if improvement. 2. In severe exacerbation, that is an FEV1 of 40% or less, if there is no improvement after initial treatment. A. Administer oxygen. B. Administer nebulized SABA plus ipratropium, hourly or continuously. C. Let's look at consideration of adjunctive therapies. 3. If there is good response to above treatment and maintained for at least 60 minutes, A. Continue inhaled SABA. B. Continue OCS course. C. Consider initiating an ICS, if patient is not already taking one. D. Discharge home. 4. If there is incomplete response, that is an FEV1 40% to 69%, admit to hospital ward. A. Continuation of inhaled SABA is recommended. B. Administer systemic corticosteroids, via oral or intravenous routes. C. Let's look at consideration of adjunctive therapies. 5. If there is poor response, that is an FEV1 of 40% or less, admission to intensive care is recommended. A. Continuation of inhaled SABA, hourly or continuously. B. Administer intravenous corticosteroid. C. Consideration of adjunctive therapies. D. Possible intubation and mechanical ventilation. P. We will now look at additional vaccines. Adults with asthma aged 19 to 64 years should receive 1. The 23-valent pneumococcal polysaccharide vaccine, abbreviated as PPSV23, Pneumovax, once, then follow U.S. Centers for Disease Control and Prevention (CDC) recommendations for pneumococcal vaccination at age 65 and older. 2. Administer influenza vaccine every fall or winter. Q. Let's now discuss asthma in pregnancy. 1. Asthma may worsen, improve, or stay the same during pregnancy. 2. Asthma may increase the risk of perinatal mortality, hyperemesis, vaginal hemorrhage, preeclampsia, complicated labor, neonatal mortality, prematurity, and low birth weight infants, especially if it is uncontrolled. Risks are small and are not shown in all studies. 3. Medications. The preferred controller is budesonide ICS, the only category B ICS. However, if asthma is well controlled on another ICS before pregnancy, it may be continued. B. The preferred rescue inhaler is albuterol. C. Labis, a category C, with less clinical experience. Use during pregnancy is reasonable if necessary for asthma control. Salmeterol is the preferred LABA. D. LTMs have limited data, most data are with montelukast. It is category B, and the data for montelukast are reassuring. These are considered an alternative therapy. E. Prednisone is category C. Potential adverse effects in pregnancy are cleft palate, preeclampsia, gestational diabetes, low birth weight, and prematurity. However, few studies involved patients with asthma, and women might have been exposed to longer-term prednisone use. Prednisone should be used, if necessary, for acute exacerbations in pregnancy. Let's switch gears to chronic obstructive pulmonary disease, abbreviated as COPD. Relevant guidelines include Global Initiative for Chronic Obstructive Lung Disease, abbreviated as GOLD. Global Strategy for the Diagnosis, Management and Prevention of COPD. 2019 update. Available at www.goldcop.org/. Accessed February 7, 2019. Kassim A. Wild T.J. Weinberger Shea, A.L. Diagnosis and Management of Stable Chronic Obstructive Pulmonary Disease, a Clinical Practice Guideline Update from the American College of Physicians, American College of Chest Physicians, American Thoracic Society, and European Respiratory Society ACP, ACCP, ATS, as guidelines. An Intern Med 2011, 155-179-91. Regarding its definition, COPD is a common, preventable, and treatable syndrome of persistent limitation in expiratory airflow encompassing both small airway disease, obstructive bronchiolitis, and parenchymal destruction, emphysema. Airflow obstruction may be accompanied by airway hyperresponsiveness and may not be fully reversible. Airway and alveolar abnormalities are usually caused by significant exposure to noxious particles. 1. Chronic bronchitis consists of persistent cough plus sputum production for most days of 3 months in at least 2 consecutive years and is an independent disease entity that may occur before or after the development of airflow limitation. 2. Emphysema is abnormal permanent enlargement of the airspaces distal to the terminal bronchioles, accompanied by destruction of their walls and without obvious fibrosis. Emphysema is only one of several structural abnormalities in patients with COPD. B. Regarding the diagnosis and assessment of COPD. 1. The clinical diagnosis of COPD is based on a history of exposure to risk factors and the presence of airflow limitation that is not fully reversible, with the presence of symptoms. A. Symptoms: dyspnea, described by patients as increased effort to breathe, heaviness, air hunger or gasping, poor exercise tolerance, chronic cough, sputum production, wheezing. B. GOLD guidelines perform spirometry and consider COPD if a patient is older than 40 and has any of the following. 1. Dyspnea that is progressive, that is worsens over time, persistent, that is present every day, and worse with exercise or on exertion. 2. Chronic cough that is present intermittently or every day, often present throughout the day, seldom only nocturnal, may be non-productive. 3. Chronic sputum production in any pattern. 4. History of exposure to risk factors, especially tobacco smoke, which is the most common risk factor, occupational dusts and chemicals, and smoke from home cooking and heating fuels. C. American College of Physicians, American College of Chest Physicians, American Thoracic Society, and European Respiratory Society (ACP, ACCP, ATS, ERS) guidelines. The single best predictor of airflow obstruction is the presence of all three of the following: 1. Smoking history of more than 55 pack years. 2. Wheezing on auscultation. 3. Patient's self-report of wheezing. 2. For the diagnosis and assessment of COPD, spirometry is the gold standard. A. Spirometry revealing an FEV1 to FVC ratio less than 70% of predicted is the hallmark of COPD. Bronchodilator reversibility testing is no longer recommended. B. Measurement of arterial blood gas tension should be considered for all patients with FEV1 less than 50% of predicted or clinical signs suggestive of respiratory failure or right heart failure. C. On the basis of the spirometry result, a gold grade is assigned: 1. Gold 1, in which there is mild FEV 80% or greater of predicted. 2. Gold 2, that is moderate FEV 50% to 79% of predicted. 3. Gold 3, that is severe FEV 30% to 49% of predicted. 4. Gold 4, that is very severe FEV less than 30% of predicted. 3. We should assess the frequency of exacerbations in the past 12 months. A. Less severe refers to 0 or 1 exacerbation not leading to hospital admission. B. More severe refers to 2 or greater or 1 or greater leading to hospital admission. 4. We should use validated symptom scales or questionnaires. A. The CAT measures health status impairment in COPD. It can be accessed at www.catastonline.org. 1. It measures not just breathlessness but also cough, sputum production, chest tightness, limitation of activities, sleep, energy level, and confidence to leave house. 2. It uses a scale of 5 to more than 30. A. 5 is upper limit of normal. B. Less than 10 is low impact on life. C. More than 30 is high impact on life, that is can barely leave the house. B. MRC breathlessness scale for assessing severity of breathlessness was published in Thorax in 1999. 1. It measures severity of shortness of breath or breathlessness. 2. It uses a scale of 0 to 4. A. 0 applies to least symptoms, breathless only with strenuous exercise. B. 4 applies to too breathless to leave house. Such patients are breathless even when dressing. C. Let's now consider the factors determining severity of COPD. They include: 1. Severity of airflow limitation FEV1. 2. Frequency and severity of exacerbations. 3. Severity of symptoms, basing on MRC, or CAT. 4. Presence of comorbidities that may restrict activity, e.g., heart failure, heart disease, musculoskeletal disorders. D. The therapy goals include the following: 1. To relieve symptoms. 2. To reduce the frequency and severity of exacerbations. 3. To improve exercise tolerance. 4. To improve health status. 5. To minimize adverse effects from treatment. Pause the video and carefully scrutinize Table 11 summarizing grades for strength of recommendations for COPD guidelines. 2. The existing medications for COPD have not been shown to modify the long-term decline in lung function, the hallmark of this disease. This is a level of evidence A. Therefore, pharmacotherapy for COPD is used to decrease symptoms, complications, or both. 3. Smoking cessation is a critical component of COPD management for patients who are actively using tobacco. 4. Bronchodilator medications are central to the symptomatic management of COPD. This is a level of evidence A. Primary mechanism in COPD is through changes to smooth muscle tone that result in airway widening. B. It can be given as needed or on a scheduled basis to prevent and reduce symptoms. C. The principal treatments are beta-2 agonists, muscarinic antagonists, and a combination of these drugs. D. Inhaled therapy is preferred to oral therapies because of less systemic exposure. E. Combining agents from different classes may improve efficacy compared with increasing the dose of a single bronchodilator. F. Triple therapy improves lung function and health-related quality of life while reducing the number of exacerbations. G. Short or long-acting bronchodilator is recommended as initial treatment for all COPD groups. 1. Group A consists of short or long-acting bronchodilator to help with breathlessness. 2. Group B consists of long-acting bronchodilator. There is no preference over LABA or LAMA. 3. Group C consists of LAMA for initial monotherapy. 4. Group D, here the initial treatment individualized. A. LAMA for most patients. B. Severe symptoms e.g., CAT greater than 20 use a LAMA plus a LABA. C. Elevated eosinophils e.g., greater than 300 cell per microliter use a LABA plus an ICS. H. Adding tiotropium to a LABA and ICS combination triple therapy improves lung function and health-related quality of life and reduces the number of exacerbations. This is a level of evidence BI. Treatment with a LAMA delays first exacerbation, reduces the overall number of COPD exacerbations and related hospitalizations, improves symptoms and health status. This is a level of evidence A, and improves the effectiveness of pulmonary rehabilitation. This is a level of evidence B. LAMAs have no effect on the rate of decline of lung function. Initial studies with tiotropium showed increased cardiovascular risk, but newer strong evidence shows no increase in risk. Anticholinergics may not significantly improve FEV1. LABAs improve health status, quality of life, and FEV1 and decrease COPD exacerbation rate. This is a level of evidence A. LABAs have no effect on mortality or rate of decline of lung function. Salmeterol reduces hospitalization rate. This is a level of evidence B. Salmeterol significantly reduces the number of patients needing hospitalization, as well as treatment for exacerbations. Indacaterol significantly improves breathlessness, health status, and exacerbation rate. This is a level of evidence B. Indacaterol is a LABA with a significantly greater bronchodilator effect than salmeterol and a bronchodilator effect similar to that of tiotropium. This is a level of evidence A. LABAs do not have the same potential safety concerns as with use in asthma. Let's now compare LAMAs versus LABAs. 1. In the POET COPD study, tiotropium was more effective than salmeterol as initial bronchodilator therapy in moderate to very severe COPD regarding time to first exacerbation and annual number of exacerbations. This was published in the New England Journal of Medicine in 2011. 2. Cochrane Review. Tiotropium is more effective than LABAs in preventing COPD exacerbations and COPD-related hospitalization but not in overall hospitalization or mortality. Symptom and lung function improvement were similar. However, studies are sparse. Fewer serious adverse events and withdrawals from studies occurred with tiotropium than with LABAs. Cochrane Database SystRev 2012, 9, CD 009157. 3. The FLAME trial showed greater efficacy with the combination of LAMA plus LAMA, that is indacaterol plus glycopyrrolate, than with the combination of LABA plus ICS, that is salmeterol plus fluticasone, in preventing COPD exacerbations in patients with a history of exacerbations in the previous year. This was published in the New England Journal of Medicine in 2016. Let's discuss triple therapy. 1. Triple therapy has been shown to improve lung function and health-related quality of life, while reducing the number of exacerbations. 2. The first triple therapy single inhaler was recently approved and contains an ICS, that is, fluticasone furoate, LABA, that is, vilanterol, and LAMA, that is, omeclidinium. 3. The FULFILL trial showed improvements in FEV1 and moderate to severe exacerbations with triple therapy compared to ICS and LABA, Lipson D.A., Barnacle H., Burke R. al. FULFILL trial, once daily triple therapy for patients with chronic obstructive pulmonary disease. This was published in the American Journal of Respiratory Critical Care Medicine in 2017. 4. The IMPACT trial further demonstrated benefits compared to ICS and LAMA and LABA through lower rate of moderate to severe COPD exacerbations compared to both dual treatments and lower rate of COPD hospitalizations than LAMA and LABA, Lipson D.A., Barnhart F., Brealey N. al. Once daily single inhaler triple versus dual therapy in patients with COPD. This was published in the New England Journal of Medicine in 2018. 5. We will now discuss ICSs in stable COPD. A. They are not recommended as monotherapy in COPD and may increase risk of mortality compared with use in combination treatment. B. They work as anti-inflammatory agents to theoretically decrease airway inflammation with multiple COPD exacerbations. C. Blood eosinophil counts may predict the magnitude of ICS effect in preventing future exacerbations. D. Use in combination with LABA benefits patients with moderate to severe COPD and continued exacerbations, particularly with an eosinophil count greater than 300 cells per microliter. E. The effect of an ICS on lung function, health status, and exacerbations is decreased if patient continues to actively smoke tobacco or when eosinophils are less than 100 cells per microliter. F. There is an increased risk of pneumonia, oral candidiasis and hoarse voice exists when ICS is used. G. There is a greater risk of exacerbation following withdrawal of ICS when eosinophil count greater than 300 cells per microliter. H. Group CICS plus LABA is alternative for treatment intensification when eosinophils greater than 300 cells per microliter and history of exacerbations. 1. Group D LAMA plus LABA plus ICS as treatment intensification when eosinophils greater than 100 cells per microliter, LABA plus ICS as alternative initial treatment when eosinophils greater than 300 cells per microliter. 6. Patient assessment and selection of therapy. A. GOLD guidelines combine symptoms on the basis of symptom scores, airflow limitation on the basis of post-bronchodilator FEV1, and frequency of exacerbations to determine patient risk group and recommended treatment, as shown in Figure 1 and Table 12. B. ACP, ACCP, ATS, ERS guidelines simplify treatment even further on the basis of FEV1 in patients with COPD with symptoms. They do not provide detailed treatment guidelines as shown in Box 1. Pause the video and carefully scrutinize Figure 1 summarizing GOLD guidelines, refined assessment of COPD severity and risk. Pause the video and carefully scrutinize Table 12 summarizing GOLD guidelines, pharmacotherapy for stable COPD. Pause the video and carefully scrutinize box 1 summarizing ACP, ACCP, ATS, ERS guidelines, treatment recommendations for stable COPD. 7. We will now look at other pharmacologic treatments. A. Phosphodiesterase type 4 inhibitor, abbreviated as PDE4 inhibitor. Roflumilast, marketed as Daliresp 1. Indication: PDE4 inhibitors may be used as a daily treatment to reduce the risk of COPD exacerbations in patients with severe COPD, with an FEV1 less than 50% of predicted associated with chronic bronchitis and a history of frequent exacerbations despite treatment with LABA plus LAMA plus ICS, particularly if eosinophils are less than 100 cells per microliter. In these patients, studies show a reduction in exacerbations and a reduction in the composite endpoint of moderate exacerbations treated with oral or systemic corticosteroids or severe exacerbations necessitating hospitalization or causing death. This is a level of evidence B. These effects also occur when roflumilast is added to long-acting bronchodilators. This is a level of evidence B. No trials have assessed the effects of roflumilast on COPD exacerbations when added to an ICS plus long-acting bronchodilator combination. No comparison of adding roflumilast versus ICS to long-acting bronchodilators is available, now being studied. 2. These drugs reduce inflammation through inhibition of the breakdown of intracellular cyclic adenosine monophosphate. They exert no direct bronchodilator activity. 3. The dose of roflumilast may be started at 250 micrograms orally once daily for 4 weeks, then increased to the maintenance dose of 500 micrograms orally once daily. This dose titration may allow for better GI tolerance. 4. PDE4 inhibitors are contraindicated in cases of moderate to severe liver impairment and in nursing mothers. 5. These medications can cause weight loss monitor and psychiatric events, including suicidality monitor, weigh risk-benefit ratio in patients with pre-existing psychiatric illness. 20% of patients studied had weight loss of 5% to 10% of body weight, compared with 7% with placebo. Average weight loss was 2 kg. 6. Its adverse reactions include diarrhea, weight loss or decreased appetite, nausea, headache, back pain, influenza, insomnia, and dizziness. 7. Use with strong cytochrome P450 (CYP) enzyme induces, e.g., rifampin, phenobarbital, carbamazepine, and phenytoin is not recommended. Use with CYP3A4 inhibitors or dual inhibitors of CYP3A4 and CYP1A2, e.g., erythromycin, ketoconazole, and fluvoxamine, increases roflumilast exposure and adverse effects. The risk-benefit ratio must be weighed. 8. According to the ACCP-CTS guidelines to prevent exacerbations, roflumilast is suggested for patients with moderate to severe COPD with chronic bronchitis and a history of at least one exacerbation in the past year. B. Regarding antibiotics, we recommend the use of azithromycin. 1. Its actions are anti-inflammatory and antibacterial. 2. Daily azithromycin at 250 mg orally daily for 1 year was found to lengthen time to first exacerbation, decrease overall exacerbation rate, and improve quality of life. This was published in the New England Journal of Medicine in 2011. 3. Azithromycin 500 mg orally 3 times per week and erythromycin 500 mg orally twice daily have reduced exacerbations, as published in the Lancet Respiratory Medicine in 2014, and in the New England Journal of Medicine in 2011. 4. Its potential adverse effects include hearing loss, contradictory evidence, pneumonia, GI disturbances, and QTc prolongation. 5. Recommended as add-on to treatment intensification with LABA plus LAMA with or without ICS if eosinophils are less than 100 cells per microliter and the patient is a former smoker. C. Smoking cessation therapy is essential for all patients. D. Regarding vaccinations, 1. The influenza vaccine should be administered to these patients annually. It is essential for all patients. 2. PPSV23, pneumovax, should be administered once before age 65, then in accordance with CDC recommendations for pneumococcal vaccination at age 65 and older. 3. The 13-valent pneumococcal conjugate vaccine, abbreviated as PCV13, marketed as Prevnar, should be administered once after age 50 and at least 1 year after PPSV23. Next we will discuss alpha-1 antitrypsin augmentation therapy. This is a level of evidence B1. This is a once-weekly intravenous therapy of an alpha-1 proteinase inhibitor, marketed as Aralast NP, Glacier, Prolastin C, and Zamira. 2. It is for young patients with a severe hereditary alpha-1 antitrypsin deficiency and established emphysema, but it is expensive. 3. Patients with an alpha-1 antitrypsin deficiency are usually white, usually have COPD at a young age, that is younger than 45 years, and have a strong family history. It may be worthwhile to screen such patients. 4. Alpha-1 antitrypsin deficiency should be considered in patients with frequent COPD exacerbations. This was published in the Cleveland Clinical Journal of Medicine in 2016. 8. We will now look at non-pharmacologic therapy of COPD. A. We will begin with home oxygen therapy. 1. It is recommended in patients who have a PaO2 of 55 mm of mercury or less, or 55 to 60 mm of mercury if they suffer from pulmonary hypertension, peripheral edema, or polycythemia. This is a level of evidence D, or SaO2 of 88% or less, with or without hypercapnia, confirmed twice during a 3-week period. This is a level of evidence B2. It results in improved survival with long-term, that is more than 15 hours per day, use in patients with chronic respiratory failure. B. Pulmonary rehabilitation is essential for patient groups B to D. This is a level of evidence A1. It includes exercise training, nutrition counseling, and education. 2. It is recommended for COPD stage 2 to 4 COPD, with referral when patients have moderate stage 2 COPD instead of waiting until it is more severe. 3. It improves many outcomes in COPD, including quality of life and survival. Next we will discuss lung cancer screening. 1. USPSTF recommends annual lung cancer screening for aged 55 to 80 years old who have a 30-pack-year smoking history and currently smoke or quit less than 15 years ago. 2. There are concern related to appropriateness of recommendations as lung cancer is leading cause of death in patients with COPD. 3. It has been suggested to change to a greater than 1-pack-year threshold for patients with COPD to lead to a higher life expectancy than currently seen according to Lowry K.P., Gazelle G.S., Gilmore M.E., al. Personalizing annual lung cancer screening for patients with chronic obstructive pulmonary disease, a decision analysis. This was published in Cancer Journal in 2015. 9. Let's progress to other medications in COPD. A. Regarding beta blockers, 1. Observational data suggest that long-term treatment with beta blockers reduces risk of exacerbations and improves survival, even in patients without overt cardiovascular disease. This was published in the Archives of Internal Medicine in 2010. 2. More than half of the patients studied had cardiovascular risk factors or coronary artery disease. Mostly cardioselective beta blockers were used. 3. It is too early to recommend beta blockers for the treatment of COPD, but beta blockers should not be withheld in patients with COPD who also have heart disease, chronic heart failure, or other cardiovascular conditions in which beta blockers are beneficial according to the Cochrane database in 2002. There was an update in Cochrane database in 2005. 4. The mechanism of benefit in COPD is unknown, but beta blockers can upregulate beta-2 receptors in the lungs, which may improve the effectiveness of inhaled beta agonists. B. Regarding statins. 1. Several retrospective studies have found benefits for statin use in COPD for reducing exacerbations and COPD-related mortality. This was published in Thorax Journal in 2015, in the American Journal of Respiratory Critical Medicine in 2013, in the American Journal of Medicine in 2013. 2. The prospective STAT-COPE trial found no significant effect of simvastatin on the number of severe COPD exacerbations per person year compared with placebo. This was published in Chest Journal in 2015. 3. The Rotterdam study found a 78% lower risk of mortality in patients with COPD and high-sensitivity C-reactive protein concentrations greater than 3 mg per deciliter, which indicate a higher level of systemic inflammation. This was published in Pulmonary Pharmacological Therapeutics Journal in 2013. 4. Strong prospective evidence does not exist to suggest that statins provide a clinical benefit in patients with COPD who have no other cardiovascular disease risk factors. F. We will now discuss the management of acute exacerbations of chronic COPD. 1. A COPD exacerbation is an acute worsening of a patient's baseline respiratory symptoms, e.g., dyspnea, cough, and/or an increase in quantity or purulence of sputum, that is worse than normal day-to-day variation and results in a change in medication. The diagnosis is based purely on clinical presentation. 2. Regarding classification A. In the mild category we should use short-acting bronchodilators only. B. In the moderate class we should use short-acting bronchodilators plus antibiotics and/or oral corticosteroids. C. In the severe class hospitalization or ED visits is recommended. 1. No respiratory failure refers to cases where the patient has a respiratory rate of 20 to 30 breaths per minute, there is no use of accessory muscles, there is no mental status changes, hypoxemia improved with supplemental oxygen, and there is no increase in PaCO2. 2. Acute respiratory failure, non-life-threatening refers to a case where the patient has more than 30 breaths per minute, accessory respiratory muscles are in use, there is no change in mental status, hypoxemia is improved with supplemental oxygen, PaCO2 is increased compared to baseline 3. Acute respiratory failure, life-threatening, more than 30 breaths per minute, accessory respiratory muscles are in use, there are acute changes in mental status, hypoxemia is not improved with supplemental oxygen, PaCO2 is increased compared to baseline or the patient has a pH of 7.25 or greater. 3. The common precipitating factors include infection of the tracheobronchial tree and viral upper respiratory tract infections, which is the most common, and air pollution. However, the cause of 1/3 of exacerbations cannot be determined. 4. Spirometry is not accurate during an exacerbation and is not recommended. 5. Pulse oximetry can be used to determine the need for supplemental oxygen, which should be given in severe exacerbations. In exacerbations necessitating hospitalization, arterial blood gas measurement should be performed. 6. Inhaled bronchodilators, that is inhaled SABAs with or without short-acting anticholinergics, are the preferred treatment of COPD exacerbations. This is a level of evidence ca. The usual dose of albuterol is 2.5 mg by nebulizer every 1 to 4 hours as needed, or 4 to 8 puffs by MDI with holding chamber every 1 to 4 hours as needed. B. Short-acting anticholinergics, e.g. ipratropium, are generally added for acute exacerbations. 7. Systemic corticosteroids are effective, and they shorten recovery time, improve FEV1, and improve hypoxemia. This is a level of evidence A. They also lower the risk of treatment failure and early relapse rate and shorten hospital stays. Systemic corticosteroids should be used in most exacerbations. OCS dose for outpatient treatment, that is 40 mg of oral prednisone once daily for 5 days, is recommended in the GOLD guidelines. This is a level of evidence B, but insufficient data are available to provide strong conclusions about the optimal duration. A. Higher daily doses or oral prednisone or prednisolone may be used, e.g., 50 to 60 mg daily. B. A recent study showed that in patients with a COPD exacerbation presenting to the hospital, a shorter course of systemic corticosteroids, lasting 5 days, was non-inferior to a longer, 14 days, course with respect to re-exacerbation within 6 months. This was published in JAMA in 2013. 8. Antibiotic treatment should be initiated for exacerbations if the criteria below are met. The most common pathogens in COPD exacerbations are Streptococcus pneumoniae, Haemophilus influenza, and Moraxella catarrhalis. In patients with GOLD 3 and 4 severity, Pseudomonas aeruginosa infection becomes an important pathogen. A. The 3 cardinal symptoms in COPD exacerbations are increased dyspnea, increased sputum volume, and increased sputum purulence. 1. Antibiotics should be given if all 3 cardinal symptoms are present. This is a level of evidence B. 2. Antibiotics should be given if 2 of the 3 cardinal symptoms are present and if increased sputum purulence is one of the symptoms. This is a level of evidence C. 3. Antibiotics should be given to patients with severe exacerbations requiring mechanical ventilation. This is a level of evidence B. B. The recommended duration of antibiotic treatment is usually 5 to 7 days. This is a level of evidence B. C. We will now discuss the recommended antibiotics. 1. Empiric treatment consists of amoxicillin with clavulanic acid, a macrolide, e.g., azithromycin, or a tetracycline, e.g., doxycycline. 2. If antibiotics have been used recently, that is in the last 3 months, use an alternative class. 3. In complicated COPD with risk factors, amoxicillin, clavulanate, levofloxacin, and moxifloxacin are the antibiotics of choice. Regarding risk factors, they include comorbid diseases, severe COPD, with an FEV1 less than 50% of predicted, more than 3 exacerbations per year, and antibiotic use in past 3 months. 4. If the patient is at risk of Pseudomonas infection, administer high-dose levofloxacin, dosed at 750 mg, or ciprofloxacin and obtain sputum culture. Regarding risk factors, they include 4 or more courses of antibiotics in past year, recent hospitalization, in the past 90 days, isolation of Pseudomonas during past hospitalization, severe COPD with an FEV1 less than 50% of predicted. 5. If exacerbation does not respond to the initial antibiotic, sputum culture and sensitivity should be performed. We will now discuss gout. Relevant guidelines include the following: Canna D., Fitzgerald J.D., Canna P.P., al. 2012 American College of Rheumatology Guidelines for Management of Gout. Part 1. Systematic non-pharmacologic and pharmacologic therapeutic approaches to hyperuricemia. Arthritis Care Res 2012, 64 to 1431-46. Canna D., Canna pp., Fitzgerald, J. D. al. 2012 American College of Rheumatology Guidelines for Management of Gout. Part 2. Therapy and Anti-Inflammatory Prophylaxis of Acute Gouty Arthritis. Arthritis Care Res 2012, 64 to 1447-61. Cassim A., Harris R. P., Forcia M. A., al. Management of Acute and Recurrent Gout, a Clinical Practice Guideline from the American College of Physicians. An Intern Med. 2017 166 1, 58-68. Primarily for reference only, ACR guidelines are most commonly cited. A. Regarding the definition of gout, it is a spectrum of clinical and pathologic features caused by hyperuricemia, serum urate concentration more than 6.8 to 7 mg per deciliter, resulting in tissue deposition of monosodium urate monohydrate crystals in the extracellular fluid of joints and other sites. It is the most common rheumatic disease of adults. Its prevalence estimated at 3.9% of adults, that is 8.3 million, in the United States. B. Regarding its diagnosis 1. Gout typically presents as acute episodic arthritis. 2. It may also present as chronic arthritis of one or more joints, particularly if prolonged hyperuricemia exists. 3. Tophi may be present, they are detected on physical examination or with imaging and pathology. 4. Renal manifestations include urolithiasis. 5. Features of acute gouty attack include a. Severe pain, redness, swelling, maximum severity in 12 to 24 hours, may continue for a few days to several weeks. B. Most often affecting in the lower extremities in a single joint 1. The most commonly affected joint is the first metatarsophalangeal joint podagra or knee. 2. It may occur in many other joints, including those of upper extremities 3. It may be polyarticular at first presentation, in less than 20% of cases 6. Ideally, definitive diagnosis should be made by visualization of monosodium urate crystals under polarized compensated light microscopy in fluid aspirated from the affected joint during an acute gouty attack. A. In the diagnosis of gout, monosodium urate crystals are negatively birefringent, that is needle-shaped or rods. B. In pseudogout, crystals are calcium pyrophosphate dihydrate and are weakly positively birefringent, that is rods or rhomboidal. C. Diagnosis by joint aspiration is difficult because patients are in severe pain and often refuse joint aspiration during an acute attack. In this case, a provisional diagnosis may be made according to clinical data. 7. If diagnosis by joint aspiration is not possible, a tentative diagnosis may be made by a combination of presentation or clinical picture and increased uric acid. The use of hyperuricemia as one of the criteria for diagnosing gout may be difficult during an initial acute attack because serum uric acid may be low during flares. The best time to check uric acid is 2 weeks after a flare. C. Its predisposing factors as listed in the Current Opinion Rheumatology published in 2011 include 1. Dietary factors like high meat and seafood consumption, fatty foods, dietary overindulgence, high intake of beer and spirits, not wine, in men, sugar-sweetened soft drinks, and high fructose foods. 2. Drugs like xanthine oxidase inhibitors, abbreviated as XAOIs, and uricosuric agents with initial therapy, thiazides and loop diuretics, niacin, calcineurin inhibitors, low-dose aspirin, that is, 325 mg per day or less. 3. Medical conditions and other factors. They include obesity, diabetes, hypertension, dyslipidemia, metabolic syndrome, congestive heart failure, organ transplantation, renal insufficiency, early menopause, trauma, surgery, starvation, dehydration, and episodic alcohol consumption. D. Regarding its classification, 1. There are 4 stages of gout: A. Asymptomatic. B. Acute gouty arthritis. C. Intercritical gout, that is intervals between attacks. D. Chronic recurrent gout. 2. Severities of chronic tophaceous gouty arthropathy, abbreviated as CTGAA. Mild, involves one joint, it is stable disease. B. Moderate, here 2 to 4 joints are involved, it is stable disease. C. Severe 1. Chronic CTGA of more than 4 joints or 2. 1 or more unstable, complicated, severe articular tophy. 3. Size of joints: A. Large joints, e.g., knee, ankle, wrist, elbow, hip, and shoulder. B. Medium joints, e.g., wrist, ankle, and elbow. C. Small joints, e.g., interphalangeal. E. Regarding treatment goals: 1. The minimum serum urate target is less than 6 mg per deciliter. 2. A serum urate target of 5 mg per deciliter or less may be needed to improve gout signs and symptoms. Consider a goal of 5 mg per deciliter or less if tophi are present. 3. Decrease the frequency of acute gouty attacks. Pause the video and carefully scrutinize Table 13 non-pharmacologic therapy for gout. G. Regarding pharmacologic treatment of hyperuricemia: 1. Consider discontinuing non-essential medications that cause hyperuricemia. 2. Recognize indications for urate-lowering therapy, abbreviated as ULTA. Tophi on clinical examination or imaging study. B. 2 or more acute gouty attacks per year. C. CKD stage 2 or worse. D. Past urolithiasis. 3. ULT may be initiated during an acute gouty attack as long as concomitant anti-inflammatory therapy is given. 4. The first-line treatment is a xanthine oxidase inhibitor, e.g.A. allopurinol or febuxostat. B. Switch to alternative XOI in patients intolerant of or refractory to first XOI. 5. Alternative first-line include probenecid, A. A uricosuric if at least one XOI is contraindicated or not tolerated. B. A history of urolithiasis and a creatinine clearance, CR/CL, less than 50 ml per minute per 1.73 meters squared contraindicates first-line use of probenecid. C. Increased urinary uric acid indicates uric acid overproduction and is a contraindication to use of uricosuric ULT. 6. Add-on therapy include lesinurad, A. It is a selective uric acid reabsorption inhibitor. B. It is a first in the class. C. It is used only as add-on to allopurinol or febuxostat in those that do not achieve serum uric acid levels. 7. Initiate anti-inflammatory prophylaxis for acute gout concomitantly with or just before ULT in all patients. A. There may be an early increase in acute gouty attacks during initiation of ULT. 1. It may be caused by rapid decrease in urate concentrations, resulting in remodeling of articular urate crystal deposits. 2. It often leads to non-adherence to ULT, meaning that patient education is critical. B. Oral low-dose colchicine is the first-line option. C. The other first-line option is low-dose nonsteroidal anti-inflammatory drugs, NSAIDs. This is a lower evidence grade than colchicine. Add a concomitant proton pump inhibitor or other agent for suppression of peptic ulcer disease when indicated. DOCS is an alternative for anti-inflammatory gouty attack prophylaxis. This is a level of evidence C.1. It may be used if colchicine and NSAIDs are contraindicated, not tolerated, or ineffective. 2. Because of the risks associated with prolonged use of OCSs, the risk-benefit ratio of this strategy should be considered and re-evaluated with continued ULT therapy because the risk of acute gout decreases in time. Anti-inflammatory prophylaxis of acute gout should continue for the greater part of 1. 6 months. This is a level of evidence A. 2. 3 months after achievement of target serum urate concentration. If no TOFI, this is a level of evidence B. 3. 6 months after achievement of target serum urate concentration. If TOFI were previously present but have now resolved, this is a level of evidence C. 4. Anti-inflammatory prophylaxis continued in presence of any clinical evidence of gout disease activity, TOFI, recent acute gouty attacks, chronic gouty arthritis. 8. We should check serum urate every 2 to 5 weeks. After the goal is achieved, continue monitoring every 6 months. If serum urate goals are not achieved, A. Titrate single-agent XOI to maximum appropriate dose. 1. Allopurinol doses greater than 300 mg per day can be used, even with renal impairment, as long as appropriate patient education and toxicity monitoring are provided, e.g., rash, increased liver function parameters. 2. Substitution of another XOI should be considered if drug intolerance and adverse events occur. B. Next, add uricosuric to XOI, e.g., probenecid, losartan, or fenofibrate. Probenecid is a first-line uricosuric, while losartan and fenofibrate are off-label but recommended second-line uricosurics. C. If the goal serum urate is still not achieved, add pegloticase only if the gout disease burden is severe and the patient is refractory to or intolerant of other ULT options. Pegloticase is not recommended for first-line therapy in any case. 9. Indefinite ULT is recommended. 10. Allopurinol hypersensitivity syndrome (AHS) is possible. A. It poses a risk of severe morbidity and hospitalization. B. There is a mortality rate of 20% to 25% in AHS. C. The manifestations include Stevens-Johnson syndrome, toxic epidermal necrolysis, clinical constellation of symptoms, that is, eosinophilia, rash, vasculitis, major end organ disease. D. Highest risk exists during the first few months of therapy. E. The risk factors include concomitant thiazide diuretics, renal impairment, Han Chinese or Thai descent, irrespective of renal function, and Korean descent with stage 3 or worse CKD. Consider testing for HLA-B*5801 in these ethnic groups. Presence indicates higher risk of AHS. We will now discuss the treatment of acute gout. 1. We should assess the severity of the gouty attack, as shown in Table 14, and select treatment according to severity. 2. We should then initiate pharmacologic treatment within 24 hours of onset of an acute gouty attack as directed in Table 15. Colchicine is appropriate only if initiated within 36 hours of attack onset. 3. We should continue established ULT without interruption during acute gouty attack. Do not discontinue ULT, and now pause the video and carefully scrutinize Table 14 summarizing severity, duration, and extent of acute gouty attacks. A. For mild to moderate pain affecting one or a few small joints or one or two large joints, use monotherapy, with either NSAID or OCSs, or colchicine. This is a level of evidence A for all choices, supplemented with topical ice as adjunctive therapy, as needed. 1. There is no preference for one choice over another. Select the treatment according to gout flare presentation, comorbidities, previous response, and patient preference. 2. Consider intra-articular corticosteroids if one or two large joints are affected and use OCSs, for all other presentations. Single-dose intramuscular triamcinolone followed by an OCS may be considered. 3. Concomitant use of colchicine with P-glycoprotein (P-G-P) inhibitors or strong CYP3A4 inhibitors is contraindicated in renal or hepatic impairment. fatal toxicity has occurred. 4. The colchicine dose should be reduced if renal or hepatic function is normal and there is concomitant use of PGP inhibitors or moderate to strong CYP3A4 inhibitors. 5. If the patient has undergone acute gout treatment with colchicine in the past 2 weeks, use an alternative therapy. 6. Colchicine should not be used to treat gouty attacks in patients with renal or hepatic impairment who are taking prophylactic colchicine, according to labeling. 7. Celecoxib is an option in certain patients with contraindications or intolerance to NSAIDs. The risk-benefit ratio is unclear. 8. Adrenocorticotropic hormone 20 to 40 international units subcutaneously is an option if the patient cannot take medication by mouth. B. For severe pain or polyarticular attack, or if multiple large joints are affected, use initial combination therapy. Full doses of both agents may be used, or, when appropriate, the full dose of one agent and a prophylactic dose of another agent. 1. Colchicine plus an NSAID. 2. OCS plus colchicine. 3. Intra-articular steroids with all other modalities. 4. Combination of an NSAID and systemic corticosteroids. There is synergistic GI toxicity. C. Continue acute treatment until the gouty attack has resolved. 4. In some instances, response to initial treatment of an acute gouty attack is inadequate. A. Inadequate response is defined as either less than 20% improvement in pain score in 24 hours or less than 50% improvement in 24 hours or more after starting drug therapy for acute attack. B. Switch to a different monotherapy. This is a level of evidence C, or add a second agent. This is a level of evidence C. C. Biologic agents that inhibit IL-1, e.g. anakinra and canakinumab, are considered investigational for the treatment of acute gout but may be considered when gout flares are frequent and resistant to all other therapies. 5. Educate patients and provide prescriptions so that patients can initiate treatment for acute gouty attacks on their own. Pause the video and carefully scrutinize Table 15 summarizing medication dosing for gout. Pause the video and carefully scrutinize Table 15 summarizing medication dosing for gout. For recommended adult immunization schedule United States, 2019, see pages 47 to 52 of the manual. A. Regarding general immunization guidelines 1. Basic recommendations for immunization of adults are based on age and specific vaccines. See Figures 2 and 4. 2. Certain medical conditions require special consideration when determining whether additional immunizations are recommended. See Figures 3 and 4. 3. On the basis of patient-specific factors, specific vaccines or formulations should be avoided or used with caution. B. Regarding contraindications and precautions 1. Do not administer a vaccine when a contraindication is present due to an increased risk for a serious adverse reaction. A. Live vaccines should generally be avoided in patients that are severely immunocompromised. B. Pregnant women should not receive live, attenuated vaccines due to theoretical risk to the fetus. 2. In general, vaccines should be deferred if a precaution is present based on the risk of experiencing a more severe reaction to the vaccine. This risk is less severe than with a contraindication. A vaccine can be administered when a precaution is present if the benefit outweighs the risks. B. All vaccines have a precaution for administration in a patient with a moderate or severe acute illness with or without fever. 3. Full lists of contraindications and precautions are available in package inserts or within the ACIP Best Practice Guidelines for Immunizations www.cdc.gov/vaccines/HCP/ASAP-REX/general-REX/contraindications HTML. C. Major changes in the 2018 and 2019 adult immunization schedule include the following. 1. In the case of zoster vaccines, administer 2 doses of recombinant zoster vaccine, abbreviated as RZV, marketed as Shingrix, to adults 50 or older. A. Doses should be given 2 to 6 months apart. B. Administer this vaccine regardless of past episodes of herpes zoster or past vaccination with zoster vaccine live, abbreviated as ZVL, marketed as Zostavax. C. Among adults 60 or older, administer either RZV or ZVL, however RZV is preferred. 2. Men-B, which is a serogroup B meningococcal vaccine, is a meningococcal vaccine now available for use in individuals 10 years and older at increased risk of serogroup B meningococcal disease. The other available meningococcal vaccine, MenACWY, contains serogroups A, C, W, and Y. MPSV4, is a 4-valent meningococcal polysaccharide vaccine, is no longer available. Both Men-B and MenACWY may be administered at the same time at different sites. Recommendations for use of Men-B vaccine include the following. A. Adults with anatomical or functional asplenia or persistent complement component deficiencies should receive either Men-B4C or Men-B-FHB, in addition to MenACWY. B. Men-B is not routinely recommended for adults with HIV infection. C. Microbiologists routinely exposed to Neisseria men in GTDs should receive either Men-B4C or Men-B-FHB, in addition to MenACWY. D. Young adults between 16 and 23 years old, who are healthy and not at an increased risk of serogroup B meningococcal disease may receive Men-B4C or Men-B-FHB, for short-term protection. 3. The HPV vaccine series may be reduced to 2 doses at least 5 months apart if the series is started before age 15 years. 4. Hepatitis B vaccine administered as Heptasav B requires only 2 doses at least 4 weeks apart and may be used as a substitute in a 3-dose series. 5. Hepatitis A is now indicated to be given when homelessness is present. D. Regarding pneumococcal vaccination, 1. PCV13, marketed as Prevnar, should be used for adult pneumococcal vaccination in people 65 and older, in addition to PPSV23, marketed as Pneumovax. 2. Pneumococcal vaccine-naive patients 65 and older should receive PCV13 at age 65 or older and PPSV23 at least 1 year later. 3. Patients who previously received PPSV23 at 65 or older should be vaccinated with PCV13 1 year or more after PPSV23. 4. Patients who previously received PPSV23 before age 65 who are now 65 or older should be vaccinated with PCV13 1 year or more after receipt of PPSV23 and revaccinated with PPSV23 at least 1 year after PCV13, as long as 5 or more years have passed since the previous PPSV23. 5. The interval between PCV13 and PPSV23 is at least 8 weeks for people with immunocompromising conditions, anatomical or functional asplenia, cerebrospinal fluid leaks, or cochlear implants. 6. Patients should be vaccinated at 19 to 64 years of age with PPSV23 if they have the following disease states: A. chronic heart disease e.g. heart failure and cardiomyopathies. B. Chronic lung disease e.g. COPD, emphysema, and asthma. C. Chronic liver disease, cirrhosis, and alcoholism. D. Diabetes. E. Alcoholism. F. Cigarette use. G. It is no longer recommended for residents in nursing homes or long-term care facilities, as sole indication for administration. E. Let's now discuss influenza vaccination. 1. Regarding egg allergy. A. If an adult has an egg allergy of any severity, recombinant influenza vaccine, abbreviated as RIV, which does not contain any egg protein, may be administered. B. If an adult has experienced only hives after eating eggs or egg-containing foods, he or she can safely receive inactivated influenza vaccine, abbreviated as IIV, with additional safety measures. Avoid live-attenuated influenza vaccine nasal spray. C. Some people who report egg allergies may not actually be allergic to eggs. Those who can eat a lightly cooked egg, e.g., scrambled egg, without a reaction are not likely allergic and can safely receive any influenza vaccine. 2. Regarding the live attenuated influenza vaccine. A. It is available as a nasal mist. B. ACIP recommends against use during the 2017 to 2018 flu season because of its low efficacy in past flu seasons. The 2018 to 2019 ACIP recommendations state that providers may choose to administer any licensed, age-appropriate influenza vaccine, including LAIV4. F. Regarding the herpes zoster vaccine. 1. It is marketed as Shingrix. A. It is the preferred herpes zoster vaccine product. B. Zoster vaccine is recombinant. C. It is administered as a 2-dose regimen at 0 and 2 to 6 months. D. Its efficacy is close to 90% compared with placebo. E. It is the preferred zoster vaccine. F. Its storage and reconstitution are different from those for Zostavax. 1. It is stored in refrigerator. 2. It should be used within 6 hours of reconstitution. 2. Let's briefly look at Zostavax. A. The package insert states that Zostavax is not to be given concurrently with PPSV23, instead, they are to be separated by at least 4 weeks because of decreased immunologic response to Zostavax. Their conclusion is based on an unpublished Merck-sponsored study. B. The ACIP states that the clinical relevance of this recommendation is unknown, and a subsequent study showed no compromise in Zostavax efficacy. C. ACIP-CDC, which reviewed the data, continues to recommend that Zostavax and PPSV23 be administered at the same visit if the person is eligible for both vaccines. G. Regarding the HPV vaccine. 1. 9-valent HPV vaccine, abbreviated as 9V, HPV, is available and may be used for routine HPV vaccination of both females and males. 2. HPV vaccine recently had expanded ages approved for use. It is now approved to be used in males and females aged 9 to 45 years old. Recommendations for use have not yet been updated to include this expanded age range. 3. Bivalent, abbreviated as 2V, HPV, and quadrivalent, abbreviated as 4V. HPV vaccines were recently removed from the market. 4. The series is 2 doses when started before age 15, with at least 5 months between doses. If the series is started after age 15 or the doses are separated by less than 5 months, the 3-dose series is still recommended. 5. Revaccination with 9V, HPV is not recommended if the complete regimen of 2V, HPV or 4V, HPV has previously been received. The 9V, HPV regimen may be completed if started with the 2V, HPV or 4V, HPV product. 6. The FDA recently expanded the indicated age range for administration to 45 years old in both males and females. However, the ACIP 2019 recommendations for age of administration have not changed from prior years. Thank you.